Our first speaker is Dr. Remya. She will be talking on optic neuritis. She is a pediatric ophthalmologist from Cooperative Hospital, Payyanur.
Okay. Good morning. So I'll be talking on optic neuritis. Optic neuritis as such is an inflammation of the optic nerve. So it's a demyelinating inflammation of the optic nerve. There are many causes of optic nerve inflammation. So typically we'll be dealing with demyelinating inflammation of the optic nerve. So optic nerve can get affected from any part of its course. So it can be intraocular till the chiasma optic tract. So when it is intraocular, you call it as a optic disc edema papillitis. But if it is behind the optic disc, you call it as a retrobulbar neuritis. Okay, so let me start with a case. This is a 44-year-old lady with loss of vision in the left eye in one day. She had pain on eye movements. There was no other neurological deficit. Vision was 6.6. Left eye vision was counting finger 1 meter. Anterior segment examination was normal except for a grade 3 RAPD. And this was her fundus. Everything normal. And the field effect shows generalized depression in the left eye. Otherwise, right eye was normal. So considering this, we will call it as left eye retrobulbar optic neuritis. So we have sent the patient for an MRI orbit with the gadolinium contrast and fat suppression. So you can see there is an increased intensity in the left optic nerve, and which is enhancing in the contrast. So this is an MRI brain normal. So this is a case of isolated demyelinating optic neuritis. There are no MRI brain lesions. Okay. So we gave a treatment of IVMP 1 gram daily for 3 days, followed by oral prednisolone 1 milligram per kilogram for 11 days and a short-term taper as according to our ONTT trial. And after 3 weeks, she started improving her vision and color vision. So why we should do MRI brain? Because optic neuritis is present in 50% of cases with multiple sclerosis, and 20% multiple sclerosis optic neuritis is the presenting feature, and it is the strongest predictor for clinically defined multiple sclerosis. So the lesions in the multiple sclerosis in brain can be periventricular, juxtacortical, subcortical, or infratentorial as in cerebellum. So typically what you get this type of lesions in the periventricular area is called as a Dawson's fingers. So why it is important? Because if there is no lesion in the MRI, there is only 25% risk of MS in the next 15 years. Whereas if you have one lesion, 60%, 2, 68, and 3, 78. It keeps on increasing. So there is a devised McDonald's criteria. I am not going into the details, but you should know two terms. That is dissemination in space and dissemination in time. Dissemination in space means you have different lesions in different locations. Whereas in different dissemination in time means you have lesions of different ages. The previous MRI can be normal and a new lesion appears. Or in the same MRI, there is a lesion which is enhancing, one which is not enhancing. That is suggestive of an old lesion. So when you call it typical optic neuritis, either it is an isolated or it is associated with a multiple sclerosis. So the characteristic features are it usually occurs in young or middle age with a female preponderance, acute or subacute loss of vision associated with pain and decrease in color vision and contrast. So vision, not only the visual acuity, you should also check the color vision, especially the red desaturation and contrast sensitivity and visual field. So visual acuity, it can be 20/20 to profound loss of vision, that is no PL. So you should get all the other tests also get done. And visual acuity, it reaches a trough in the first week, then it starts improving by second to third week, comes back to almost normal by 4 to 5 weeks, then over the next few months it comes back to normal. Okay. Then the color visual field, it can be from a normal field to a diffuse loss or an altitudinal field loss, central scotoma, centrocecal scotoma, or anything can happen in visual fields. And pupil, normally optic neuritis is unilateral, so you will get a RAPD. And visually evoked potential, you will get an increased P100 latency. So there are some phenomena associated with this optic nerve. One is Pulfrich phenomena. What happens normally when a pendulum rotates from one side to another, it moves in a linear fashion. But if you have an optic neuritis, what happens is there is decreased conduction on one side. So the patient will see a parabolic effect rather than a linear thing. Okay. Then Pulfrich phenomena I have already explained. Next is the Lermit sign. So sudden flexion of the neck that will cause an electric shock like sensation. And Uthoff's phenomenon, the increase in body temperature leads to decrease in visual acuity as at the deepening of the scotoma. These are more associated with the multiple sclerosis than an isolated optic neuritis. And this is your landmark study, ONTT trial. So here we have 3 arms, IVMP, oral steroids and placebo. So even if you don't treat or you treat, the ultimate visual acuity will be normal in any case. But why you should treat? That answer comes from the ONTT trial. Because the visual field and visual acuity recovery is almost same in all cases. But what you should know is the probability of recurrence of optic neuritis is maximum with oral steroids. And the clinically defined MS in the first 2 years is minimal with the IVMP. So that is why you should treat with an IVMP. Because it will not affect your vision as such. So how can we alter the disease course? So these are the different drugs used. So if you treat your MRI lesions, you can definitely prevent or delay the development of multiple sclerosis. I am not going into the study. These are the champion study and all these compare the drugs. Okay. So now let me come to the second case. This is a 21-year-old boy, sudden loss of vision in the right eye for 4 days. There was pain on eye movements. And when probing, he gave a history of similar episodes. And the second episode, he had vision first affected left eye, followed by the right eye, and he was started on IVMP and azathioprine. And now when he showed me, he had his right eye was affected. So his vision was counting finger, grade 3 RAPD with a disc pallor in the right eye. And the MRI, I don't have the picture, sorry. Thickening of the right optic nerve extending to the optic chiasma. You should note that it is extending up to the optic chiasma. It's a long lesion. And even in the left eye, there was non-enhancing hyperintensity suggestive of a previous attack. So this was his fundus. The right eye shows a disc pallor and the right eye has a field defect. So what is atypical in this case? One thing, it is bilateral. There was history of recurrence. And another thing was, whenever he was on steroid, whenever his treatment is reduced, he again gets the symptoms. So there was a steroid dependence and pain was lasting for more than 2 weeks. So atypical optic neuritis you should suspect when the age is less than 12 and more than 50. If there is bilateral involvement or recurrence, progressive vision loss for more than 10 days, steroid dependence, severe disc edema, lack of pain or pain lasting more than 2 weeks, or associated with the constitutional symptoms. That I will come to later. So we have two main types. This is the NMO, that is neuromyelitis optica, and the MOG, myelin glycoprotein. So how you differentiate these three, I will just tell you. In multiple sclerosis, you will get a short segment involvement in an optic nerve. And the upper part of the spinal cord is involved. Sorry. Upper part of the spinal cord is involved and it is short segments. And in the brain, you will get a pericortical involvement. Whereas in MOG, the perineural sheath involvement is happening and the chorda equina part, it is more in the lower part, and you can get area prostrema involvement. Whereas in NMO spectrum disorders, you can get bilateral involvement, long segment involvement, chiasmal involvement, even up to the optic tract. And not only the white matter, even the grey matter can also get involved. You can see the central and as well as the peripheral, and it involves the cervical and thoracic part. And wherever the aquaporin 4 antibody is there, all these parts can get affected, and that's why leading to symptoms like vomiting, nausea and narcolepsy. So you should ask these symptoms in these patients. So I'm not going into the details, and in atypical cases you should ask for, send for all these antibodies, and this is how you treat. If you have a typical patient, send for MRI brain and orbit with fat suppression and gadolinium contrast, IVMP and oral prednisolone, treat for MS depending upon the MRI brain lesions. If you have atypical lesions, NMO, MOG antibody, LP, brain orbit and spine, and IVMP followed by oral prednisolone, plasmapheresis, long-term immunosuppression. This is all what I told today, how to differentiate between NMO, MOG and multiple sclerosis. Thank you.
Thank you, Dr. Remya, about optic neuritis in such a